In limited resources settings, less than 0.5% of children born with an isolated cleft palate present to a cleft treatment center in their first week of life. The systematic examination of every newborn's palate and attention to correct technique can shorten the time of referral for expert assessment, feeding and emotional support, and treatment, and save many lives. Visual inspection is the most reliable way of identifying structural abnormalities in the mouth affecting the gums, palate, and tongue. Cleft palate may be suspected when there are feeding difficulties, when milk is coming out of the nose during feeds, and when the baby is making noisy wet sounds while feeding. There may also be breathing difficulties caused by the tongue falling back into the palate defect. The tools needed for the examination are a tongue depressor, either a wooden spatula, plastic spatula, sterile 1 ml syringe, or the handle of a clean teaspoon. And a good light, such as a pen torch or the torch of a mobile phone. The infant's arms may be restrained by an assistant or the mother, after explaining the purpose of the examination. For example, hold the head gently and firmly with one hand, or restrain the head with one hand while the other holds the baby's 2 arms as they are gently pulled together on the lower part of the chest. This allows a clear view of the mouth to look for possible causes of feeding difficulties. The tongue is pressed down on the direct vision, placing the spatula, 1 ml syringe, or teaspoon handle towards the back of the mouth where it may elicit a gag reflex. Avoid pushing the depressor into the back wall of the throat. Look at the whole of the palate, including the uvula, for a cleft of the palate or a bifid uvula, and from the back to the front of the mouth for a cleft of the gum, neonatal teeth, and abnormal size or shape of the tongue. A short frenulum is common in the newborn, but it is unusual for it to cause tongue tie sufficient to interfere with feeding. A cleft of the palate extends from the back of the palate towards the front of the mouth. It may involve the soft palate or extend forward to include the hard palate almost up to the back of the gums. The cleft in this baby is a cleft involving the soft and the hard palate. The following pictures show a selection of clefts of different shape and size involving the soft and hard palates. This shows a cleft of the soft palate. This, a wider cleft of the soft extending into the hard palate. A larger cleft of the soft palate and hard palates is shown in this picture. A cleft of the soft palate and a submucous cleft of the hard palate. What to do if the visualization of the palate is insufficient to exclude a cleft palate? Examination is not always successfully completed. The mouth being small, the infant, although restrained, may be upset and the examiner may subsequently desist. So, some babies' palates will not be fully visualized. The parents should be informed of this, and another inspection should be conducted shortly before mother and baby are discharged. This is an essential safeguard in the drive to reduce unnecessary harm caused by the lack of or delayed detection. A child with a cleft requires immediate feeding assistance and medical attention. To refer the parents and the child to the nearest cleft treatment center, you may use the Cleft Care Companion app, which can be downloaded for Android and iOS. This application includes a range of helpful information on clefts, and when you click on this icon showing map at the bottom of the screen, you can find the closest cleft treatment center. The name and the address of the nearest facilities, along with the names of the contact persons and phone numbers, are also provided, such as to ease the reporting and referral of new patients.